Well, when it comes to organ transplantation and specifically lung transplantation, no parent is obligated to make this choice. This is not experimental therapy, but it is heroic therapy. Because there are very few pediatric lung transplant programs, it often involves families being separated, one parent and a child living in a place like Houston for several months, and usually the father and other children staying at home. So I try to make the choice as clear as it can be. This is a therapy that's really only indicated if patients have a very poor quality of life and a low prospect of survival beyond 2 years. We're often dealing with a child who's never known what it feels like to be healthy. We're sometimes dealing with a child in a family who until recently didn't know or didn't want to confront the ultimate prognosis. So I try to recognize that my first interaction with the family, we may be in the middle of a grief process. So I try to be understanding, informative, tender if appropriate. I always try to add a little humor. And I always engage families very deeply. I ask about their faith, non-judgmentally, and it's my way of letting them know that we're dealing with some very serious questions. The numbers of transplants done in infants, children, and adolescents are far lower than in adults. The survival, when you look at entire adult cohorts and pediatric cohorts, is about the same, which is about a 50+% survival at 5 years. It's gotten a little better over time, but this is the organ transplant that has the greatest complications and the worst survival. Nonetheless, the vast majority of the kids will survive the surgery, the transplant hospitalization, will get out of the hospital off oxygen, and have a chance of enjoying a measure of health that was literally almost inconceivable before the surgery. So I've initiated in the last year an almost obligatory conference call to include the referring physician or physicians, especially if the child's in the hospital, and the parents, to begin this discussion, to kind of frame what their questions might be, what their expectations might be. And I always say, some good, loving parents say, no thank you. And we don't judge those people. On the other hand, we want them to know what the option might be. Fortunately, in 2014, insurance is rarely a barrier to pursuing transplant. I think sometimes living costs and the disruption of a family can be. I often tell older kids and families, the goal is not for you to make a decision this week. Your goal is to find out, check out the people who you would be trusting your child's life and your life if you're the child with, and then go home and think and pray and talk to your own doctors, and then we can have a conversation and we can have second visits. A fair number of our patients are not yet sick enough to need to relocate and be listed. And we really like that because it allows the seed to be planted. I mean, I've got patients right now who are dealing with rejection and beginning to be concerned that their dream is being dashed before their eyes, while there are others that are waiting for transplant and others who are just having a great time after transplant. I'm concerned that many of my colleagues around the country and around the world allow their own perception of what may be suboptimal outcomes to influence their willingness to consider, educate their patients and families, and to refer them to appropriate centers.